Good afternoon, everyone, and welcome to the fifth session of the training series, Implementing Medication-Assisted Treatment in Recovery Residences. My name is Jennifer Reha, Recovery Consultant with C4 Innovations, and if you have not already done so, please do take a moment to type your name and the recovery residence or organization you're affiliated with in the box to the lower left on your screen called Chat and Questions. We're so excited to have all of you joining us today. I do see some names already coming in, so great, thank you. This event is brought to you by the Substance Abuse and Mental Health Services Administration's Opioid Response Network and the Pennsylvania Alliance for Recovery Residences. Our Technical Assistance Center is dedicated to increasing access to recovery supports, and we achieve this work through a variety of mechanisms, including through technical assistance focused on systems transformation, developing the capacity of peer-run recovery community, and family and youth-led organizations. I do want to inform you that today's webinar will be our final training session in this series. Unfortunately, due to lower than anticipated attendance, session 6 has been canceled, and we will be summarizing the series and providing an opportunity for questions and answers at the end of today's session. I am pleased to introduce today's presenter, Jenna Nesbitt, Recovery Consultant with C4 Innovations, who will be presenting on stigma, both in society but also within recovery residences. I'll be turning things over to her shortly, but first I'd like to review a few housekeeping items with you all. Please remember to mute your speakers if you are calling into the webinar, and remember to mute your microphones. The computer speaker can be muted by pressing on the green horn on the upper left-hand or middle corner above the video feed. Throughout today's sessions, we will be asking for your participation in several discussion questions, and you'll find the chat box on the left side of your screen. We invite you to participate in the discussion questions by typing your comments there in the box. We also have several resources related to this webinar available for download from our webinar resources box. To download a file, simply click on the name of the document, then click Download File. This event is being recorded, and the recording link will be shared with all registrants after the event. You'll be able to review the chat and rewatch the presentation using that link. So with that, I will turn it over to Jenna.
Thanks, Jennifer. Good afternoon, everyone. My name is Jenna Nesbitt, and as Jennifer said, I am a recovery consultant with C4 Innovate. I'm also a woman in long-term recovery, and what that means for me is I've not used any substances since June 29th, 2012. And yes, I have a birthday coming up, so you can email me after if you'd like to know what's on my wish list. As with all of the sessions in this series, this particular technical assistance is brought to you by SAMHSA State Targeted Response, as Jennifer indicated. The Opioid Response Network assists STR grantees, individuals, and other organizations by providing the resources and technical assistance they need locally to address the opioid crisis. Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorders. The Opioid Response Network does provide local experienced consultants in prevention, treatment, and recovery in communities and organizations to help the opioid crisis. The ORN accepts requests for education and training, and each state territory has a designated team led by a regional technology transfer specialist who is an expert in implementing evidence-based practices. So, oh goodness, thank you for forwarding the slides, Vanessa. I'm just going to disclose to the audience my contact lens fell apart today, so I am struggling with old glasses as we deliver the training for you today. You can contact the Opioid Response Network to submit a TA request at any time, and there's the information right there. So there are portions of this presentation that have been adopted from Dr. Sarah Wakeman's original work done with PCSS-MAT, and it also includes elements from Faces and Voices of Recovery's message training. So let's talk a little bit about stigma basics. We've mentioned stigma a few times so far in our previous trainings, and today we're going to discuss stigma in a little bit greater detail. So what is stigma and why does it matter? In order to connect the dots, we need to first turn to a few basics in history about SUD, substance use disorder, and addiction, which you may recall from our first session, there's a difference. As this slide indicates, substance use disorder is a broad category, whereas addiction has more concrete defining variables, and dependence also has a different definition from substance use disorder, which I'm not going to read. It's right there on the screen for you. But these are very important distinctions. How we define SUD and addiction makes a difference in the language. First of all, substance use disorder is a public health issue, and addiction is a disease in and of itself. So while other psychiatric disorders often co-occur with addiction, addiction is not a manifestation of another mental illness. However, substance use disorder and addiction can arise from coping with mental health problems. As such, when someone has developed an addiction, it then becomes a primary chronic disease. By definition, to have addiction, someone must still use despite terrible consequences. This can be the hardest part for family members and the public to come to terms with because addiction seems completely irrational. It is a disease that, through conditioning, changes the way the brain works, as we reviewed in session 1, and it diminishes rational decision-making and ability to weigh risks and benefits. So just like the person with a stroke may be unable to use language or move part of their body, a person with addiction is literally unable to use the part of the brain that can look at negative consequences and make a rational judgment about whether or not to use. It is also, for many people, a chronic disease, meaning that people don't get cured, and rather treatment allows an individual to manage their illnesses and minimize relapse. It is about 40 to 60% genetic, meaning that just like heart disease or diabetes, about half of an individual's vulnerability to develop addiction is based on what genes they were born with. So addiction has the same trajectories and outcomes as other chronic illnesses, yet people with addiction are treated poorly, and they are shamed. The change in biology in addiction is much like that of heart disease. And relapse, or probably in friendlier language that's not a stigma, recurrence of substance use is common in addiction, just like it is a relapse or recurrence with other chronic health diseases. It happens at about the same rate. So there's been a policy history with stigma and substance use disorder. I'm sure everybody has heard the terminology, the war on drugs, which originated in the 1900s with various movements against narcotics, and with the formation of one of the first drug control bureaus led by Harry Anslinger, and which preceded the Harrison Act, Anti-Narcotic Act legislation of 1914. The war on drugs was carried on throughout the nation's administration with a dramatic increase in the size and presence of federal drug control agencies, and was reinvigorated by the Reagan administration's Just Say No effort and the passing of the Anti-Drug Abuse Act imposing mandatory minimums. This also continued on through the Bush era with staggering militarization of enforcement, and the legacy was echoed by the Clinton administration, which rejected ending the federal ban on funding for syringe access programs, as well as the U.S. Sentencing Commission's recommendation to eliminate the disparity between crack and powder cocaine sentences. So as you can see, this is a bipartisan issue that's happened historically. It can't be attributed to any sort of political affiliation, because the Obama administration did reduce the disproportionate sentencing penalties of cocaine to crack from 100 to 1 down to 18 to 1. But there is still a significant disparity. So as you can see, historically, we have not responded to or treated substance use disorder or addiction with the same level of compassion and care as we have other chronic illnesses. So take a look at the question on the screen and really contemplate, what if we treated other diseases or illnesses the way we treat substance use disorder? To illustrate this point, it is useful to imagine what it might look like if we treated other chronic illnesses like we treat addiction. And we can take a look at that. So as you read over the bullet points, imagine if you went to the hospital with chest pain and were found to be having a heart attack. What if the doctors and nurses told you it was your fault because of the diet you chose, or the fact that you don't exercise or smoke? What if, even worse, they refused to give you treatment because you had done this to yourself? What if, instead of immediate care, you were given a list of phone numbers for cardiologists to call and then sent on your way? What if, instead of being given life-saving medication, you were told you could only get medication if you agreed to go to counseling? Or what if you were kicked out of care for having a symptom of your disease? This all sounds outrageous, but when you apply it to heart disease, this is what people in addiction face every single day. They are blamed for their disease. They are denied treatment, told to find the care themselves, denied life-saving medications like Suboxone, methadone, or naltrexone, and they are kicked out of care for having a symptom of their disease, namely using substances. As we recall the history of how addiction has been treated in our country, we may conclude that it is stigmatized while heart disease and diabetes are not, because the substance that typically is associated with the disease may be illegal, whereas high-fat, sugar, simple carbohydrate foods are not. We need to help people separate the legality and illegality of the substances from the disease, and when the disease has occurred and it is diagnosed, it needs to be treated as a disease, regardless of the legality or illegality of the substance that triggered the disease. So on the flip side, what if we treated substance use disorder the way we treat other diseases? If we brought substance use disorder and addiction treatment in alignment with other models of health care, we would see better outcomes, such as the reduction of mortality. Let's take a look at that. If we aligned substance use disorder, addiction treatment with other healthcare models, this is how things would look. That people who need access to substance use disorder would have it immediately. The system would run in a smooth, optimal manner where a person could move into the system from any fixed point of entry, regardless of the symptomology that's being expressed. So we don't have this system. Also, we have a lack of parity, we have prejudice, we have discrimination, and stigma are the reasons why, with policy, we see some of this. So why does care look so different? In a World Health Organization study of 18 most stigmatized social problems in 14 countries, drug addiction was ranked number 1, with alcohol addiction ranking number 4. Stigma associated with poor mental and physical health among people who use drugs is one of the most stigmatized conditions as demonstrated by this WHO study, and it's been supported by much more research. Stigma is among the top reasons that people do not access treatment. We know stigma is a huge issue in addiction because it is the number 1 reason why people who don't access it. We also know from studies across the world that drug addiction is the most stigmatized condition, as I've said. So digressing from that, we have a popcorn chat box for you, a quick little opportunity to interact. And what we are wanting to know today is why do you think people with addiction illnesses are treated differently? I'm going to give you guys a little bit of time to answer that. We'll leave that particular chat box up for a few minutes. So as we move through the remainder of the session, feel free to continue to type your answers. So what is stigma? As you can see on the PowerPoint, there are a couple of variables that make a difference. Cause and controllability are one. And we see stigma decrease when people perceive a person's substance use disorder or addiction or any other stigmatized condition as not that person's fault or they can't help it. This makes a lot of sense when we think about what stigma actually is. So stigma is defined as a characteristic or condition that is socially discrediting, and it is mainly influenced by whether you think someone is to blame and whether they have control over the situation. So if you think about language, When we use a term like substance abuse, which implies that someone is the perpetrator of his or own condition, it is going to make people more likely to think he or she is to blame. And that is something that the condition is under his or her control, which therefore increases stigma. How do we process stigma? HIV research around substance use disorder reveals that stigma has been associated with internalized stigma, which are negative feelings and beliefs associated with HIV and applied to the self. Another type of stigma is enacted stigma. This is the actual experiences of discrimination, which includes stereotyping, prejudice from others due to one's HIV. And then another type of stigma is anticipated stigma, expectations of discrimination, stereotyping, and prejudice from others in the future due to one's HIV. Each of these has been associated with harms to health and well-being, including underutilization of HIV medical care. What's interesting in this comparison, we use HIV a lot in the field of substance use disorder to talk about stigma because HIV was problematically, underwhelmingly examined for decades after it became a problem, and it did not receive the medical attention and policy support that it should have garnered immediately. It took decades, until the 90s, for our country to recognize and address HIV, and by then we had quite an epidemic on our hands. So you will often see people compare the battle with stigma for substance use disorder as that with HIV. Types of stigma for substance use disorder or addiction. People with addiction face many types of stigma. They face stigma from within. They may blame themselves or feel hopeless. They can face stigma even within the recovery community. This is particularly true for people on medication treatments for their illness. So while we would never shame someone with diabetes for being on insulin, people with addiction who are on life-saving medications are often shamed. They can face stigma from the people who are supposed to be treating them, with all the examples we talked about in the medical system, and even just the inaccurate belief among some clinicians that treatment is ineffective or that people don't get better. And people with substance use disorder and addiction face huge stigma from the general public because of what we discussed, as addiction being perceived as a choice and not as a disease. So here's some examples. These are bona fide, legitimately researched examples that people with substance use disorder and addiction on agonist therapy. So you may recall agonist therapy specifically refers to methadone, may not be accepted in post-acute care facilities and in some cases recovery residences. And that's ironic because people on methadone, when they're starting out, have to go do daily liquid dosing. And so sharing of medication is much more difficult with somebody who is being inducted on methadone maintenance. People who are utilizing medication-assisted treatment as a recovery pathway may not be eligible for organ transplantation. And then people mandated to treatment as a condition of probation who have positive toxicology despite treatment adherence may also be imprisoned. They face revocation. But there are definitely some other impacts of stigma that we can talk about. Regardless of where it comes from, the impact of stigma is real and huge and negative. Stigma keeps people from understanding that addiction is a valid and treatable medical condition. It can serve as a barrier to jobs, housing, and relationships. On a policy level, it allows practitioners like health insurance companies to restrict coverage. And most importantly, it keeps people from acknowledging that they have a problem and from seeking help. That's that anticipatory stigma that we talked about with regard to the work that's been done in the field of HIV. To talk a little bit more specifically about stigma in recovery residences, we've been talking with owners and operators for a little while now about how to address the operation and the structural components for a recovery residence that is preparing to or implementing accommodations for people using medications for opioid use disorder. You may remember from our first session that we talked a little bit about the addiction neurobiological and physiological implications. This is a pretty neat slide that comes directly from certified medication-assisted treatment advocacy curriculum that comes out of New York. Remember in our first session we did discuss this. Opioids are a little bit different than methamphetamine and cocaine. Like alcohol, opioids create a tolerance and withdrawal, and that is a longer-acting post-acute period for a person trying to recover than somebody who used other drugs may experience. For instance, this study in particular depicts elevated glucose metabolism in the anterior cingulate gyrus, and I am not sure if I have said that correctly, so if you're laughing at me on mute, that's totally fine. You'll see the control brain, the opioid-dependent brain on agonist therapy, and the opioid-dependent brain in sustained remission. We can now measure the brain's response to substances in real time, and the slide shows areas of the brain that are involved in opioid addiction, particularly the one all the way to the left. That is the person who has been told to go to 90 meetings in 90 days. The red shown in the brain is an indicator of that glucose metabolism, and notice that the brain in remission has a lot more red. That's a good thing. That's a good thing because that indicates that this person's brain is responding to other environmental stressors that a brain that has not had the assistance of medication may not be able to handle. And that can be a predictor of recurrence or lapse. So what are some expectations, given what we know about how addiction manifests in the brain, and specifically opioid use disorder and how opioid addiction manifests in the brain? Given that we know all of that, and science has brought all of that to our attention, a person with an addiction who has a chronic brain illness, as you can see from the slide, and the differences in brain functioning between 1 and 14 months of abstinence looks different for OUD, and a healthier brain may not appear until after 5 years of sustained remission. That's a very long post-acute withdrawal time frame. But as early as 18 months, we start to see improvements with medication-assisted treatment. So either way, we really have to look at our expectations for recovering people as they move into our spheres, and particularly our recovery residences. Also, they may have different levels of recovery capital than you or other residents do. So I'm hoping that everybody today has a basic understanding of what recovery capital is. If not, let us know in the chat box on the left, and we will get you some information about recovery capital. Let's check our expectations. So recovery residences and other sober living environments, as well as treatment centers, typically deal with NIMBY, N-I-M-B-Y, which is not in my backyard, pushback from neighbors. We are a community of people who are stigmatized for our disorders, stereotyped, and discriminated against due to prejudice. This is even more so for people endeavoring to recover from opioids using medication. In 2018, the American Bar Association indicated tackling the opioid epidemic and addiction crisis requires communities in which individuals are able to live in safe, sober environments while they improve their physical, mental, spiritual, and social well-being and gain skills and resources to sustain their recovery. The federal government, states, and localities will be key players in ensuring the safety and quality of housing that supports them on their recovery journey. And that's from the ABA Health Law section, the Health Lawyer, Volume 31, in December of 2018. That reference is provided for you at the end of our slides. So another thing that can inadvertently perpetuate stigma is singleness of purpose, or the perception of singleness of purpose. There is an ongoing debate in the 12-step rooms about whether people on MAT are actually, quote, clean, end quote, or legitimately pursuing recovery. Alcoholics Anonymous and Narcotics Anonymous have produced many pamphlets regarding this subject, although more have been produced through NA than AA, with Narcotics Anonymous maintaining that they have no opinion on outside issues. However, in print, they do maintain that there are certain principles that they uphold. As such, singleness of purpose, a tradition which began with Alcoholics Anonymous to address, quote, addicts, end quote, seeking help, was extended to provide assistance to those people still suffering from addiction. But because many recovery residences were born of 12-step fellowships, it's important to remember that singleness of purpose may also be extended by 12-step focused residences to people using MAT, which is an underpinning of both the 3rd and 11th step of these programs. One need only read about Tradition 3 in the AA literature to understand how the group's desire to help a cross-dressing heroin addict enabled them to extend love and support to someone who was so alike yet so different. Finally, the 6th tradition of both groups separates it from the philosophies of how recovery residences operate, that the 12-step groups in question will not endorse, will not finance, or will not lend its name to any related faculty or outside enterprise, lest problems with money, property, and prestige divert them from their primary purpose. Recovery residences are homes, but they are also businesses. As such, the home's programmatic leaning cannot preclude people on medication-assisted treatment, of course with the caveat that the house has the means to sustain that type of accommodation, which we've talked about in previous sessions. So if you haven't seen previous sessions, let us know. We can get you the recordings to the previous webinars so that all of this is a little more coherent. So we're going to take a closer look at language because as with all culture, most of our cultural symbols start with our language.
Jenna?
So when was the last? Yes.
I'm sorry, did you want to take a moment and we wanted to direct people to the additional chat question that we have around whether you have seen any stigma in recovery residences specifically related to people who are using MA. And so
yes.
if you have examples of that or if you've ever experienced that, we would love to hear from you.
Yes, good catch, Jennifer. Thank you so much. I did not see my hand scribbled note chat here and now. We would like to know a little bit more about the types of stigma you've seen in recovery residences, whether they're implicit, meaning not so obvious, or explicit, meaning very obvious. We understand that this is a bit of a learning curve for everybody, and there are often owners and operators who just don't know what they didn't know, and so really that's kind of the point of moving into these types of training so that we can get the word out that everybody deserves a safe and stable place to recover. Thank you, Jennifer. So as you guys are typing in the box, hopefully, about the types of things you've seen, what was the last time you heard some of these statements? Maybe somebody say you're in relapse mode, but said in a very shaming kind of tone of voice, as opposed to inviting participation in a dialogue about how the person might be feeling, what types of responses he or she may be anticipating to stressful situations, or situations where a house manager may be talking about another resident who just didn't want it bad enough with a different resident. And that's a fairly typical and common scenario. Sometimes we have a lot of boundary issues that we have to work on in recovery. You may also have heard of a person in the house tell another person in the house that that has just been evicted to come back when they decide they are ready or that they really want it. Whew. So if we truly believe addiction is a disease, some of these statements then are contradictory to excuse me, our position that addiction is a disease. And I think that there's a lot of language that has taken place in the 12-step rooms that is carried over into other spheres of recovery in the community, and that includes recovery residences. But in what other care settings do we use language like this with one another? While the social model of recovery is integral to the success of recovery residences, the way we talk to each other is a key mechanism for conveying accountability but avoiding shame. So we have an opportunity to think about the brain's recovery and how that affects the person and how our words may influence what the person is going through in the moment. This is one of my favorite quotes. This is from William White, and I do believe he quoted it from somebody else. Words have immense power to wound or heal. The right words catalyze personal transformation and offer invitations to citizenship and community service. The wrong words stigmatize and disempower. So if you want to think of some examples, take the cotton out of your ears and stuff it in your mouth. Could you imagine if a doctor said this to you or a loved one? Could you imagine taking your child to an appointment, maybe because he or she has put on a little bit of weight, and the doctor making some snide comment like this? Or another care professional, doesn't have to be a practitioner, because certainly if we're in recovery residences, it's not likely that we are clinicians. So another metaphor might be a staff member in a treatment agency or a community agency addressing us in this manner. It's just not acceptable. In no other disease care setting do we treat people punitively for the very symptoms of the disease from which they suffer. This is especially true with recovery residences historically and in treatment centers. When you think about it, however, what makes things so much more complex is that home should be your safe place. Even when you make a mistake, home should be the place that you can go to for support and nurturing within the accountability of the social model of recovery. And it's not just the care and treatment that is different. Even the language we use is different for addiction as compared to other diseases. Think about the language we use for most illnesses. It is a language that communicates compassion and patient-centeredness. We talk about cancer survivors, and suffering or enduring chronic diseases. But that is not how we talk about addiction. Yet the language we use for addiction is quite different. We call patients substance abusers. We talk about how their urine is dirty with drugs. We wouldn't call somebody with diabetes a sugar abuser or someone who is overweight a food abuser, and yet with addiction that term has been normalized, as indicated by much of the federal language still in place. So we want to stop talking dirty. One really important step if we want to fight stigma and have addiction viewed and treated like other diseases is to change our language. The term abuse or abuser is arguably the worst. The root of the word comes from a term that means wicked act or practice, or a shameful thing. And it is a term that is anchored in our collective consciousness with horrible behavior like child abuse, sexual abuse, spousal abuse. And this isn't just a matter of political correctness. There have been studies showing that if you take highly trained mental health professionals and present them with two identical patient scenarios, where the only thing that is different is whether the person is described as a substance abuser or as having a substance use disorder, we are more likely to recommend, the health practitioners are more likely to recommend punitive measures for the person described as a substance abuser. That is at the Recovery Research Institute. Y'all should Google that if you get a chance. John Kelly has done some amazing work around language and stigma. So there's something we can do if we're in any sort of community organization or an owner-operator of a recovery residence. One of the first simplest steps we can take is to perform a language audit. This strategy comes from SAMHSA Center for the Application of Prevention Technologies. Words Matter, How Language Choice Can Reduce Stigma. And the link for this is in the reference slide of this deck if you want to take a look at it. But very quickly, just performing a language audit means going through your existing materials for language that may be stigmatizing. You can use search and replace function in your electronic documents and seek out words such as addict, replace with person with addiction or person with substance use disorder, or search abuse and replace with the word use or misuse. And you want to make sure to review all of your internal documents such as your mission statements, policies, and procedures, as well as your external documents which means your forward-facing materials, such as your brochure for your resident or your application form. This is a pretty simple step, and it can be a very meaningful step. To take. So as I mentioned, John Kelly at the Recovery Research Institute has done a lot of work around this, and the recommendations are to avoid using words such as dirty, clean, abuse, and abuser when in public. We're going to talk a little bit about when some of these words are more acceptable. But when in public, staying away from that type of terminology can be very helpful for protecting the rest of the people who struggle with substance use and substance use recovery. We want to consider changing medication-assisted treatment. Sometimes the word MAT can be stigmatized. So if you're dealing with somebody who may already have a negative attitude, it's as simple as saying medications for addiction treatment or medications for opioid use disorder. We're talking about how the medications and treatment are similar to insulin for diabetes, which is not called insulin-assisted treatment, despite the importance of behavioral intervention with diabetes care. Another term that is helpful is medically supervised withdrawal. This is more accurate and less stigmatizing than the word detox. The field is moving towards medication-assisted treatment, as we previously discussed, and also really trying to embrace medication-assisted recovery as a means to shun stigma. There are some other terms as well that include pharmacotherapy, and as we mentioned, medications for opioid use disorder. Even as recently as early May of this year, another shift has been recommended in language usage, however. We've been talking about MAT and MAR. What's next? MBT? Yes, another new language term has been introduced. As of the first week of May, the Academies of Science, Engineering, and Medicine released a publication that further supports and clarifies medication-assisted treatment for opioid use disorder, and they have proposed a language change to medication-based treatment. There's some evidence to suggest that pharmacotherapy as terminology, produces less implicit bias than the term MAT. So there's a little bit more research starting to happen around the terminology MAT, MAR. There is nothing yet about MBT because that's just been introduced as a possibility by a pretty highly credentialed consortium and think tank. Suffice it to say that this is an ever-evolving crisis, and it will likely yield an ever-evolving glossary for us to consider. So remember how I mentioned that using terms like clean and dirty, detox, addict, that these are terms, in public for us to avoid. There's a great little graph here by Ashford et al. That talks about recovery dialects. It's a great tool for helping us to employ language in a non-stigmatizing way. So for instance, when I'm in a 12-step room, I identify accordingly with what that room is addressing for me. And when in public, I identify as a person in long-term recovery. I refrain from calling other addicts or alcoholics just that in public. I call them people with substance use disorders, people with alcohol use disorder, so on and so forth. You can look at this chart to see suggestions for ways to refer to others. Of course, how you refer to yourself in any setting is up to you. Please note, though, that substance abuser is never okay, and we've noted previously the discussion about this. So, move through that rather quickly, and I'm wondering if, Jennifer, before we wrap up, and Vanessa as our moderator, is it possible to take a look at anything that's come through the popcorn chat before we wrap up this session?
Certainly. Some of the input that we've had from the owner-operators and people participating regarding stigma within recovery residences had centered on a lot of the topics that we've discussed previously, including people, including recovery residence operators who still may not believe that medications are helpful or have any value. Some of other people feeling very strong opinions about people who are using medications for treatment not being, quote, sober, refusing to help them. And so, I mean, unfortunately, it continues to be a lot of the same statements or perspectives that we've heard for many years, and then, fears about how people who are using MAT may do in a recovery residence, and are they going to be successful, or are they going to divert their medications? And as you mentioned before, in many cases, sort of strange fears that really are not based in any sort of medical research about any other diseases. And so most of what people have relayed really sort of goes along with the things that we've been talking about.
Thank you for summarizing that, because as I indicated to you all at the very beginning, I'm struggling with an old glasses prescription, so there is no way for me to read the chat box and make my way through this content. It looks like it's been very active, and it seems that we have people who are here taking part of this training who seem to already know, right, that we have to be a little more compassionate and open-minded about how to deal with opioid use prevalence. I'm wondering, if anybody wants to add anything in the regular chat box as far as suggestions. How do we bring this message to other people who may have more negative opinions and who may be a little bit more outspoken about those negative opinions? And what are some ways that we can reach those individuals so that we can invite them to participate in a conversation rather than coming at them with a hard line, hard-nosed status about medication use, because it does seem quite polarized, and it's very binary. It seems like it's very much this group or that group, yes or no, and I'm sure there are some in between. But these are things to think about as we move forward.
And Jenna, one of the participants, Maria, she commented that she's actually been educating her residents in the recovery house to compare medication use for opioid use disorders to medication use for other diseases, and really trying to make the case with the residents. And that's one of the questions that came up previously with regard to why are people with addiction treated, or why do we think that they're treated differently than people with other diseases? And it seems to be pretty unanimous that people really believe that there's a lack of understanding of addiction as a disease, and that while everyone is, quote, aware of the opiate epidemic or aware of the major problems that we have in this country right now, there's really a big lack of accurate factual information about the disease of addiction and how it is a illness, it is not a moral failing, and how all of us struggle with how do we get that message out into society at large so that people understand not just that we have an opiate epidemic or that we have a problem, but truly understand what is this problem.
I think that's a pretty accurate summary of what the issue is. That's very helpful, Maria. Thank you for working to educate people regarding medication-assisted treatment and the disease nature of opioid addiction. And not so much opioid dependence, because that's a little different, but that can also include sometimes those people get stigmatized as well for being on pain management. When they may not actually meet criteria for addiction, but they are definitely dependent on these medications for pain. So it certainly speaks to a broader need for compassion in the work that we do. So as we conclude session 5, it's important to really understand and reflect on the history of SUD policy and addiction policy. I really kind of raced through that slide, to be honest with you guys. I had way more content, but I just didn't want to be too wordy with you. There's a great book called by Johann Hari called Chasing the Scream, and it gives a very big overview of the policy for addiction and substance use disorder in our country over the last more than century. So if you want to understand a little bit more about that, check it out because it will help you understand the stigmatic implications for those we serve and those who have come before us, that it's historically entrenched and it's not going to be something we can just fix overnight. We'll take each and every one of us to make a paradigm shift in order to make some changes. But in order to save lives, we have to eradicate that stigma, which is really just another word for prejudice, and prejudice will lead to discrimination. When you're working in recovery residences, and I realize there may be some people on the call who aren't in a recovery residence, so when you're working in the community alongside any recovery residence or recovery support service, treatment provider, or what have you, utilize these recovery dialects that are best for the situation. So in other words, we definitely want to ensure that we aren't calling people addicts or abusers. Gosh, if there's only 2 that you take out of your vocabulary starting today, please make it those. We can't change the marginalizing history of substance use disorder policy. We cannot change the previous ineffective treatment. However, we can shape the future, as we've talked about. I need to forward my slide. And one of the first steps we can take towards this shift is simply to change our language. Easy, right?
And one of the suggestions that Aaliyah offered is that she really feels that continuing to open up residences that support people in medication-assisted treatment and just supporting various treatment modalities, you know, in all geographic regions, that those efforts will go a long way to people being open to reducing stigma and truly understanding addiction as a disease, and that having medication as a form of treatment for it is completely normal and acceptable. And I think that those are good points as well.
Absolutely. Those really are good points. And I think it's important to note that, you know, I've done a lot of trainings recently around medication-assisted recovery, and I think it's important to highlight the message that we as a workforce that's responding regardless of what our capacity is, who are really working to support the adoption of normalizing medications. We're also not saying that every single person who has some problematic opioid use needs to be on MAT, because really that's up to the individual. That is up to the individual, and that's up to the physician. And it is the evidence-based practice. If we're not telling people about the evidence-based practice, such as what some of these comments reflect, then we're literally restricting the menu of options that are available for somebody to make their own self-directed decision. So for those of you who are out there championing this cause, we really appreciate your work. And I think with that, I'm going to turn it over to Jen, who's going to give us a little bit more information about our series summary.
Absolutely. So if you were not able to join us from the beginning, as we mentioned earlier, please do request the webinars and you'll be able to go back through those at your convenience. But just to kind of summarize some of the key points from the previous trainings, one of the first was really focusing on the neurology of addiction and the psychopharmacology around the medications that are used to treat it, how they work, what they do, and how the medications take time to be effective within the brain. And as Jenna talked about earlier, sort of the course and period of time that one would expect before you really start to see the brain heal itself and recover from the damage done by the substances. The next point being that medication-assisted treatment, medication-assisted recovery are viable, legitimate methods for reducing cravings, addressing the illness, and the negative behaviors associated with opioid use disorders. And recovery residences working to accommodate residents who are using MAT or in MAR should have the structural and operational capacity to be able to accept them and support them. And that's really where we spent some time talking about what are those operational logistics and capacity building pieces that are needed, but are somewhat different when you're not working with a population that's using medication to treat the addiction. And so looking at staffing, looking at training that's needed for the staff in the residence or training needed for the owner-operators if it's not a staffed residence. How do you deal with privacy, security? How do you deal with the group dynamics with the other residents that are in the house and the community support that's needed in order to ensure success? And then as we talked about today, the stigma is still a pervasive issue for all substance use disorders, but it is particularly negative for opioid use disorders, and still unfortunately specifically stigma with regard to medication-assisted therapy still exists. And so in closing, if we are going to curb the opioid-related mortality rates that we see, we do have to be able to provide residents with an opioid use disorder with a safe place to recover, a safe place to live, without excluding people who happen to be in medication-assisted recovery or happen to be using medication-assisted treatment as part of that process. And so as Jenna referenced, there are a variety of references here that we think would be very helpful and would be great for you to take a look at when you do have the time. And with that, we are going to go ahead and wrap up, but if you do have additional questions, please feel free to enter those in the chat box. And I do see a couple of people who have put in notes that they either need all of the recordings or they need certain ones that they missed. We'll absolutely make sure that we get those to you. If you think of something that you needed and did not get a chance to put it in the chat box, if you're in Pennsylvania, you can reach out to Fred Way. He is the he's leading up the Pennsylvania Association of Recovery Residences, and he'll be able to provide you with links and